Hi, good evening, everyone. My name is Nadira Hamid, and thank you for joining us for the next episode of Nail It with Nadira. And today we are going to talk about leaflet modification, transcatheter electrosurgery. And it's truly my honor and privilege that we have, I call them the masters of transcatheter electrosurgery, who pioneered these procedures and techniques. And we're going to learn from them in the next hour with very interesting cases. My pleasure to introduce my co-moderator, Dr. Paul Sorajja, and my faculty, distinguished faculty, Dr. Jaffar Kahn from St. Francis, New York, Jamie McCabe from University of Washington, and Dr. Tareq Helmy as well joining us from Ochsner, LSU. So without further ado, let me move my slides. Just a brief introduction. We have the upcoming CVI conference in July this year, July 24th to 26th in Austin, Texas. We look forward to seeing all of you and to learn more of these interesting cases of all not only structural, coronary, and peripheral as well. And for the very first time this year that I'm really honored to be doing this structural imaging boot camp for the heart team with my co-directors, Dr. Omar Khalik and Dr. Akil Narang, and esteemed distinguished faculty, and together sponsored by all vendors, by GE, Philips, Siemens, Abbott, and Edwards on mitral and tricuspid imaging. So highly recommend for all those imagers and interventionists as well, and CT readers who love to learn more about the mitral tricuspid imaging. So without further ado, we have a jam-packed agenda with 4 cases. And the first case is going to be done by myself and Dr. Sorajja, and the second, Dr. Tareq Helmy, and the third, Dr. Jaffar Kahn, and fourth by Jamie McCabe. So without further ado, the first case, I'm going to introduce a case of ours just about a month or 2 months ago. Is really an 81-year-old female who has a 21 millimeter trifecta AVR back in 2016, and that's due to a critical aortic stenosis. And at that time had a root enlargement and pericardial patch. Her other comorbidities include heart failure with preserved ejection fraction, hypertension, hyperlipidemia. And at the time, she was actually traveling in Kenya for a vacation, and she had developed acute shortness of breath over there with symptoms of heart failure. And she was admitted to the hospital in Kenya and was treated for her heart failure symptoms, and then flew back to the United States. And since arriving in the United States, she was re-hospitalized in an outside institution in February 2025 before presenting to our emergency with recurrent heart failure. And her surgical risk score was actually really high. In terms of a baseline transesophageal imaging, you can see here that the leaflets of the aortic valve is not only restricted, but you can see the severe eccentric transvalvular regurgitation secondary. You can see that flail leaflet of one of the neoleaflet on the left-hand side with biplane imaging. In addition to the hemodynamics, the leaflets, as I mentioned, is restricted, but also is elevated due to the severe eccentric transvalvular regurgitation at 3.7, the mean gradient of 19 with a valve area of 1.4, DI of 0.45 with a high elevated stroke volume index with the aortic regurgitation at 58, with all the echo parameters pointing to severe transvalvular regurgitation with holodiastolic flow reversal in the abdominal aorta. In terms of CT sizing, baseline CT TAVR, you can see the right coronary artery, the height was 2.4, the left mean was 4.3, but what's significant is the short VTC to the right coronary at 1.1 millimeters. And so, you know, we discussed her at the multiple disciplinary meeting. And Dr. Sorajja, your thoughts, Paul, about this case at that time when you saw her?
Yeah, I felt like we were kind of stuck. You know, Jaffar and Jamie, you've seen this 1,000 times. You've done this a lot more than I have, but we were considering the options here. It was a very short distance to the RCA, and so we thought about either Basilica or we thought about Unicorn. We decided to go ahead with Unicorn. Nadira, do you have the slide advancer? You can just go ahead. So. This is an interesting case where we took an AL1 and took an Ostado and put it in an Avacross. And then with Nadira's guiding us on echo as well, you can see on fluoro and echo, it crossed very easily into the LV. And next slide, please. This is the burn, just a single pass. It went very easily. And we're near the annular ring because we want to get as much of the leaflet avulsed as possible. Next slide, please. This is a confirmation of the Estado in the LV that Nadira got with both 3D as well as 2D. You can see it very clearly in all images in multiple different planes. So we were quite confident with the positioning of the wire. Next slide, please. At this point, we then dilated with a 3mm balloon. And once we did that, we then put the navicross in the LV. And then my surgical partner, Dr. Bapad, actually thought of something that we should try, and we had not planned it this way, but he said we should try 2 wires and 2 balloons in a way to make the split a little bit more tangential and going around, or I should say circumferential around the annulus. And we thought that was kind of an interesting thing. So then if you go to the next slide here, we put in 2 coronary guide wires, which obviously go through very easily. And then over both wires, next slide, please. You can see 2 5-0 balloons were essentially like kissing balloons. And they squeegeed a couple times, but eventually we had a really nice positioning. And you can see here on the right-hand side that we felt very confident with this. And we did this just to make sure that we'd be able to pass a valve in easily, which actually went very well. Next slide, please. You can see the buddy balloons here on the echo. Again, beautiful 3D images. You can see them side by side. You play the right-hand image. Thank you. And next slide, please. Once we did the buddy balloons, the AL catheter essentially fell into the LV. And then through that, it became a pretty routine procedure with the safari wire in the LV. And then this was a 20mm S3 because she had only a 23 trifecta. And so this is what would fit. And you can see the valve essentially passing through into the area that we had dilated. Next slide, please. And then here's a 20 S3 that was being placed. It went very smooth right into the area that we had crossed and dilated. And you can actually see on the echo, very nice images showing it straddling the annulus well there. Next slide, please. And then after we deployed, we decided to post-dilate with an 18mm true. And then for kicks, we decided to do a coronary angiogram to show that the right coronary was patent as we had hoped it would be with that low VTC and what we did. And quite surprisingly, actually, mean gradient was only 14 with a good valve area and peak velocity 2.8, and all of the AR is gone. And she did amazingly well and went home the next day, I believe. So here are the final results. You can see here on the echo, again, no AR, all of it's gone. Good positioning. I think Nadira was a little hard to see the right on the echo, probably because it's a little far field, a little anterior. But you know, we did the right coronary angiogram just for kicks to show that it was patent, and it was obviously was.
That's right.
Next slide. Thank you. So some interesting discussion. I'd love to hear Jaffar and Jamie's thoughts on this. You know, unicorn has been around for a few years. It was first described for balloon expandable, but I've come to see that actually people are also doing self-expanding valves with unicorn, which seems a bit aggressive, but I'd love to hear what you all think about that. And I guess the other thing is, when would you perform this versus Basilica? You know, I mean, you know, there's a theoretical benefit that perhaps it's a little quicker in terms of being able to sequence and pass the valve to reduce the amount of time in AR. But there is obviously the risk of leaflet avulsion and not sticking properly. And of course, we can't do this if both coronaries are at risk. So Jaffar, Jamie, your thoughts? What do you think?
Well, that's a great case, Paul and Nadira. Congratulations, and a fantastic result. So you know, can't argue with that. I think this is a really interesting set of questions, and my thinking is this. So firstly, there's a lot of misunderstanding about what the balloon does in the leaflet. So people talk about, grenading the leaflet or blasting it away or whatever. At the end of the day, it's a laceration, right? So when you take a balloon and eventually get through the leaflet, you're creating a tear, which you can put the leaflet back together. It's just unpredictable where that tear will be. And it's that unpredictability and lack of control that I hesitate with a little bit in terms of deployment. So the thing that you did, which many people do not do, which is that double balloon, making sure that you're implanting the valve inside the hole to try and maximize pinning that avulsed leaflet across the way. A lot of times, and you have to do it with self-expanding, is that the leaflet avulses immediately with the balloon dilatation. Now you just have a flapping leaflet and then you pin the valve. And I think that increases the risk of coronary obstruction. So I think understanding exactly what you're doing with the balloon and how you're performing unicorns is essential to then understand when to use it. In my practice, I'm very comfortable with Basilica. I haven't done a few unicorns. I was a bit taken aback by the unpredictability of it a little bit. Sometimes the valve deployment itself could be a bit awkward, and theoretical risk of embolization. So I actually just have gone back to doing Basilicas.
Yeah, well, that's well said. I think, it is simultaneously true that you can get amazing results, that people are kind of voting with their feet that they want something a little more straightforward and more comprehensive than Basilica. I think we all recognize that a slice alone is very meaningful and super important, but at the same time isn't how you draw it up if you had all options and an amazing array of technologies at your disposal. I also am in Jaffar's camp, which is that I worry about tears that don't go to the central orifice, don't go towards the central orifice of the valve, but rather go sideways along the leaflet, which can create a hinge point where the leaflet can kind of pivot up, right? And that's where this unpredictability comes into play. That said, we've all cursed under our breath an amazing amount trying to snare the wire through the leaflet to complete a Basilica. So, I think it's very understandable. And in the absence, it's very understandable that people would want unicorn. In the absence of any real head-to-head information, I think it is still a scenario where people are gonna sort of choose where they feel more comfortable. But I personally also prefer Basilica at the moment.
I think in your situation, it's the way you showed that case. I think if people are to do it, I encourage them to do it that way, because what you have is you're inside the sewing ring of a biprosthetic valve. So it's not going, the tear isn't going to go somewhere you really don't want it. So that's the first thing. The second thing is you tried your best to deploy the valve inside the slit that you created. And I think if you don't do that, then all you're doing is a random slit. The slit's not centerline like Basilica, it's going to be random, and then you're hoping it's pinned out of the way. So I think if you are to do it, I think the demonstration that you showed is exactly the setting and the style in which it should be done.
You like the kissing balloons? Is that?
Yeah, and I think that it makes a lot of sense to try and create a circumferential slit in which to deploy the valve. I think that was quite nice. I didn't see the actual deployment. Was there any give during the deployment, any movement, or it's pretty straightforward?
Did I mistakenly leave that out, Nadira? I feel
Yeah,
bad
I
now.
think you put it at the end. I can find it here.
Oh, if it's at the end of the slide, is that at the end of this presentation? Oh yeah,
So
let's go through this. Sorry, I was
here. Yes, this is
here
the
it is.
deployment here. Yeah.
Yeah, but you can see, I mean, this is nice because you know, just based on how it's hugging the annular ring, you know that you haven't created kind of some random tear. You know that integrity of the attachment of the leaflet at its commissures is still present, which is great, right? That is sort of, I think, the real potential of unicorn fully manifest, right? As opposed to just being like, I put in one large balloon and made a huge hole, which presumably tears the leaflet in a way that you don't, where you now are deploying a valve in the central orifice with continuity to a leaflet tear. And this clearly is different than that. So I think that your style there is very clever.
It'd be interesting to see if, like, if the valves are larger, if you would use maybe 3 balloons. I don't know. I don't know the answer to that. Because this is 2 5-millimeter balloons. So I don't know if you would take 3 5-millimeter balloons or something larger, but maybe.
Whatever it takes to get the sapien in, right?
Yeah.
Essentially. Yeah.
So, well, great discussion. Thank you for letting me share that.
That's great.
So the next one will be Jaffar, if you'd like to share your slides.
Sure. Okay, so this is just a case we did recently. And it's not particularly complex, but I chose it because I stored a lot of fluoro, so it's good to show all the it's good to show all the steps. So this is an 84-year-old female, usual risk factors. She's sort of small and round, and with severe MAC, moderate to severe MR, and moderate MS. This is her echo. So she's got, as you can see, restricted leaflets. They're all thickened. And there's the mitral stenosis, a mitral regurg that you can see. There's lots of things in the way here. Just one second. Okay, so on CT, these are her annular measurements. She's got 270 degrees of MAC. There's this anterior MAC is contiguous, as you will see in the next slide, a calcium-free zone medially. And her areas and dimensions size pretty well for a 29 sapien valve. There's that anterior calcium. It's sort of a little bit further down the leaflet. It's quite a long anterior leaflet. It ends all the way down here. So about midway, that anterior bridge of calcium. Modeling a 29 sapien valve in this annulus, we're getting a neo-LVOT of 63. That's probably generous. It's best case. Also remember, if you have a big ball of calcium you're pushing over, that's going to be pretty much 0. The skirt neo-LVOT was also suboptimal. 196 was the skirt neo-LVOT. You'd ideally like it a little bit higher. So the first thought here is to reduce the septum somewhat. But her septal thickness in diastole at baseline was already 10 millimeters. So we didn't necessarily think we could do a lot more in terms of doing 2 procedures, one to thin the septum, usually with sesame or sometimes alcohol ablation, and then Lampoon. So what we decided to do was this, which is just a base to tip Lampoon. And here are the procedure steps. We do our transeptal crossing with an Agilis because we're going to use the Agilis anyway. So we electrify the 032 wire. This Agilis is inside a 26 Gore dry seal. This septum was a little bit thick, so we did a pre-septostomy with a 14 Armada balloon just to ease the passage of 2 deflectable catheters that we're going to get across there. So once the Agilis is across, put 2 wires into the left atrium, and that will support bringing 2 Agilis catheters or whatever deflectable sheath you wish to have of your flavor across the septum and into the left atrium. Now, once you have that access, we float a swan through the mitral valve orifice, guided under echo to make sure we're in the major orifice and not trapped around any cords, and then reintroduce this confeeder wire to help make a loop around the LV with that swan catheter, with the balloon up, face it out the aortic valve, and then send a wire. This, I think, is just a 300 centimeter BMW wire that I'm sending across the septum and up the aortic valve and into the ascending aorta, which is then snared right there. So all of that work was essentially to create a veno-arterial rail along a cord-free trajectory. And that's what you see in this Agilis catheter at the bottom with a wire that's snared up. Along that rail, I then take the swan out, and I've just put an EBU catheter here with this end snare, which is sitting in the LVOT. And the rail just helps keep stable position of this end snare. I also know that I've created a cord-free trajectory. So although these steps aren't essential and you can just put the snare straight up in the apex, it provides the safety of knowing that you're not going to trap any cords. Then we position this top catheter here, which is an Agilis catheter. Inside there's a JR4 guide onto the traversal target. And the neo-LVOT here is really small. So you can see here, we on purpose choose a really high traversal target, as high as you're willing to go before you get into the transverse sinus. So that's, this turn back into the aorta is done by just counterclocking the JR inside there 90 degrees to make sure you're nice and orthogonal to the leaflet. Burn within a starter wire through the leaflet. There you can see it on both fluoro and echo. And then once it's burnt, we routinely put a balloon pump in during the laceration to make sure we're not rushing between laceration and valve deployment, because there's usually some compromise caused by the acute MR. They tend to be very stable once the balloon pumps in. Over here, you can see the flying V has been introduced. That's that inner curvature denuded surface across the mitral valve. Now, you remember that incredibly thick ball of calcium. So what we're doing here is we're applying traction, and then we're maintaining that traction, and we cut at 70 watts while flushing dextrose. So as long as you're not sort of yanking the catheters too hard, just allowing it to cut, a mixture of mechanical force as well as electrical force, you can cut through even very, very thick balls of calcium. There's the split. You see the view looking from the atrium, and then hopefully you can also see this nice cut looking down at the leaflet from the ventricle. So at this point, you already have the Agilis across. You just put the wire across, redo the septostomy, and then inflate the sapien valve. I tend to like going reasonably ventricular here, starting with the dot on the MAC. I believe this was 29 deployed at nominal. And then we look at how flared the valve is. The valve looks like it's not particularly flared. I double tap this particular one. I don't think we did a double tap. This is the result. Now, this is interesting, and we see these sometimes, or actually quite often, with big, thick anterior bars of calcium, is this discrete anterior PVL. And what happens is when you've split that bar of calcium and you pushed it away, that you're essentially using a little bit of that as an anchor, but you've got a cut in between that, especially if you've gone very, very atrial. And these are quite easily managed with plugs. So we went ahead and plugged that. I think we used, I can't remember exactly. I think we used an AVP2, but we've also used AVP4s in this location. They tend to seal very nicely. This patient had no LVOT obstruction, was discharged the next day. So I will stop with that and we can have a discussion.
Well, that's a great case. I love myself some valve and Mac, so I'm all about it. What's interesting is that when I was looking at the slice, before you put the valve in, it looked a little more lateral. And then when you showed where that, I mean, I am very familiar with having that like discrete hole of a Lampoon residual orifice that is very closable, but that looked really nicely aligned with the aortic valve. When I was looking at the first 3D on FUS, I was wondering, like, is it just where you found a soft spot that was a little lateral to the aortic valve? But then on deployment, actually, it looked like it lined up perfect. So that was, I guess I was just fooled by that, but that was great.
Great. Yeah, I'm not sure where you saw the lateral puncture. The aim was certainly to go right in the middle in front of the aortic valve.
Yeah.
And the other thing that you can't tell just mechanistically on fluoro is if you run out of real estate, you know, those catheters were coming quite close to the agilis on the pull. Rather than pull the agilis, I tend to do a clockwise torque on them. So it kind of goes down the center rather than dragging medially. So there's just a couple of things technically on that.
It did look, I was going to ask you, it did look like you were turning it clockwise because things were rotating.
Yes,
like that.
absolutely.
Yes.
Yeah.
So rotating.
It's like MitraClip, when you turn posterior, you get height.
Yeah. And just a little nicety on that, when you clock, it not only goes posterior, but a little lateral. So it's just like flying a kite, right? You just sort of clock and pull a little bit. So
Jaffar, I have a question for you. How, you know, obviously you want to go up as high as you could. You said how, and without going across a transverse sinus. So how far can you go? Because it's honestly, it's a little hard for me to judge on that echo. I mean, it looks like you're near the intervalvular fibrosa, but you know, you could almost go up to the root of the aorta. So how far do you go when you?
So in post-surgical cases, you can go up to the root of the aorta, right?
Yeah.
It's not going to be a problem. In naive chests, you've got to be careful not to get into the transverse sinus. So you can, you know, if you really just home in on that, you kind of start seeing the tissue separate and widening. So, you know, in a sort of triangular fashion, and it's not at the hinge point. It's a little bit further up the hinge point from the mitral valve. So you can creep up a little bit beyond where you see the hinge point at the mitral valve before the tissues start to thicken.
So for people like me who haven't done as many as you, how far would you say it's safe to go above the hinge point in general? Would you say 1 millimeter or 2? I mean, is there a rule of thumb that you say?
Yeah, I'm probably a couple of millimeters above the hinge point. Probably you end up about 3 millimeters below the base of the aortic valve, but that is variable. If you're post-surgical, there's no problem. Just go high. Yeah.
Okay. Because obviously it'd be nice to get as much as you could.
Yeah, exactly.
Jamie, you had a comment?
Well, I just like NPR for this. I mean, you have a great echo team. They can line it up for you, because you can also look at what I call the attack angle of the JR4. So you can, a counterclock rotation brings you anterior, but you can do that of both the steerable guide and the JR4. So you can kind of climb up the the sort of base of the anterior mitral leaflet, but then have the JR4 kind of curve back down, so it's pointing away sort of from the aortic valve. And that's, it's an important point to make sure that the approach angle of the JR4 catheter is not also pointed up, right? Because you can be in a great position and then kind of jump higher with your wire depending on how that's pointed. So you do have a couple things you're telescoping, and getting that sort of S shape almost with, counterclocking the steerable, but then clocking the JR4 a little bit, or vice versa, depending on how the anatomy lays. It's things you can play with a little, but an NPR I think is really nice for this.
And to all three of you, thanks, Jamie. I'm obviously as an imager, do the three of you find that besides 2D, the 3D and the 3D NPR is really useful for these, in terms of precision, especially for these complex procedures?
Love the MPR for this. We didn't show it. I didn't show it in these slides, but really, I think it helps guide the whole thing really nicely. So use it a lot. A little less so in the aortic valve position. Like those pictures that you showed were incredible. Usually find with the image quality, we have to go back to 2D to see the catheters lining up well for the aortic position. But for mitral, it's almost always the case.
I think that the 3D orientation is something that has limited the space in terms of what we do as structuralists. And having that orientation, it makes things so much easier in terms of steering and such. And the precision is amazing. Not only just getting there faster, but just the precision.
Mm-hmm.
Yeah.
And the three of you, I know Tareq was supposed to present a case of Batman. How would you distinguish which one to do, for our audience and, in our webinar? How do each of you distinguish which one would you choose first, Batman or Lampoon?
So if we start with the case I showed, and people are tweeting about doing Batman in native Mac, I just give you just a couple of things to give you pause. The first is, where would you cross in that case? So if you cross above that anterior bar of calcium, the balloon is just going to ride all the way up to the aorta. If you cross below it, you're not going to get rid of enough leaflet. So I think that's the first thing. And then the second thing is, when we were working Lampoon out back in 2016, one of the ideas was indeed just to balloon everything open. And when I tried it, and I tried it only once, and it made me stop, and it was obviously a native pig heart, but the balloon expanded the anterior mitral curtain. It tore through the medial trigone and ripped through the RV free wall. And so then I thought, we need to do something different. And so I think both those stories, just to say, I think you have to have a backstop. So if you have a complete ring or a valve in valve, then you can consider Batman. Otherwise, I think the control and the precision that you get with Lampoon, like the three of us are talking about these fine movements that you can make. You can be very intentional about where the cut is with Lampoon. It's, it takes a little bit longer, but ultimately a bit more predictable, I think.
It's a great point, Jaffar. You can imagine situations where you don't have circumferential restraint, and the tears of a Batman just going all different directions that are unpredictable, because that balloon is just going to expand where it's going to expand when you deploy the valve. We had one that we did do Batman with Mac, but it was all the way around. And what we found helped with precision, actually, and Nadira was there, obviously, was we did rapid pacing and we froze the leaflets. And so we knew exactly where we could go, because you do need a lot of precision. I think you're absolutely right. If you go on one side of the calcium versus the other, you're going to tear in that direction, which may be bad. And I think some of the unpredictability is that even if you're in the right spot, you really hope it tears in the direction you want it to. So there is that. But I think if you have a ring, as you said, then that makes things a lot easier. So I don't know, Jamie, how do you think about Batman versus Lampoon?
Well, I guess I'm kind of I'm still more of a Lampoon guy personally. I think people equate this to Basilica is to Unicorn what Lampoon is to Batman. And in a lot of ways that's true, but in some ways it's not, right? Obviously, delivery of the valve, you're going antegrade with Batman, whereas you're going retrograde with Unicorn. So you can have like leaflet deflection and trying to deliver the prosthesis in Batman, depending on how far down the leaflet you are and how much mobility there is. And it tends to be that you have to use a little bit, in my experience, which is limited with Batman, you have to use a bigger balloons to sort of make sure you get through the leaflet without just kind of displacing it. But I mean, I think it all speaks to the fact that that people would prefer something that feels that has fewer snares, that like has fewer pieces of equipment, and that is like, boom, boom, boom. And I think I'm not built that way. Like I find it kind of awesome when I have to sort of like put pieces together and think about
Completely agree.
like
It was Ted Feldman when I was in training in 2004, and he pulled me aside because I knew I wanted to be a structuralist, and I said, Ted, what does it take? What do I need to work on? I'm still a fellow. And he said, Paul, you need to be able to cut, and you need to be able to snare. And you need to be able to cut things, like cut catheters, cut guides, shape things, and you need to be able to fit things that don't say that they can fit. Like, AVP2 inside a 6 flexor, what size goes with what. And you're absolutely right. I get excited whenever I have to get the snare out. I mean, I really do, but that's just me. But I think you guys are like that too. But I think others maybe not so. And there is something to be said for simpler. So
One more caveat. I think simpler is great, but in the absence of a bunch of evidence. So, I think, prospective adjudicated studies with core labs with Basilica, and you can probably expand that to the shortcut trial and the telltale trial. You have, you now have a technique with a central cut, which has quite a lot of evidence. So I think lack of evidence, one, and second, just theoretically having the split go in any which direction. My personal feeling is that, we should really try and study this in a prospective way, like we did with all these other techniques. None of these we just did them and did retrospective registries. They were all NHLBI prospective studies before widespread adoption. So that's my feeling about, Lampoon and Basilica, Batman and Cleve. Yeah.
We do need prospective registries for sure. I mean, we have a lot of people who are trying these things, and it can really hurt the field. It really can. So we do need that. It looks like Jamie, you have the last case. I think Tareq, it looks like he was tied up, but Jaffar, you want to talk about your telltale trial?
Yeah.
Sure. I can talk generally about both studies. So there have been 2 studies with dedicated devices for Basilica. One was shortcut biprosthetic leaflet laceration global study, and one was telltale. That was a US study, 90 patients, 60 biprosthetic, 30 natives. The telltale results we presented at CRT earlier this year. Basically 90 patients all at high risk of coronary obstruction, procedure success and 100%, safety and 96%, which included 1 coronary obstruction and 1 disabling stroke. So that's
1 stroke out of 90?
1 disabling stroke.
Wow.
2 non-disabling strokes. Yeah.
And was Sentinel being used in most of these cases?
Not mandated. It was left to the discretion of the operator. But, I think we all feel that if we can get it in these cases, we do. So it ended up being 80% of cases. Yeah.
I'm sorry for that. Delay. Can you see my screen okay?
We can.
I'm gonna take a second of liberty just because I thought it would be fun, since you showed we were talking leaflet modification earlier, and this will come out just in a minute in circuit intervention, but very brief. Here's a left coronary that needs Basilica, and I do think that one of the challenges for Basilica remains
Jamie, we just see like your calendar invite.
Oh, you're on the wrong screen. I'm so sorry. Hold on. How about this? Can you see this?
Yeah.
Oh, very good. Yeah.
Apologies. So here's a left coronary, left coronary that needs Basilica, and I do think that one of the challenges with Basilica and Batman, for that matter, or Unicorn rather, remains the puncture. Right, because if you really have like a sheet of calcium it's kind of difficult to get across that, right?
So you're the one who's done this.
Yeah.
I heard someone's done this, and I thought, who on earth has done this? I should have known.
Well, so it's me. So we tried for a really long time to get across this leaflet. You can see calcium at the edge, but the whole thing was just planar calcium. And just deflecting wires and trying more wires and deflecting wires. And eventually I just decided that we do have another way to get across calcium, which is a rotational atherectomy burr. And so we just rotated the leaflet. And
Love it.
at 180 rotations per minute, 180,000 rotations per minute, got a good position on the leaflet. It's a 1.5 burr. Just had to sit on it. I'll play that again. We just had to sit on it for a while, and then eventually, there's no wire, obviously. Eventually, we punctured through the leaflet. The rota comes out. Now you've got a hole. You just and now you're off to the races with Basilica, because you can just find the hole with the wire, throw the wire through the hole, snare it, and be done. And the laceration.
You did this wireless. You did a wireless rota.
Yeah, well, there's no we couldn't get that was the whole point.
Yeah.
We couldn't get the wire across the leaflet. So yeah, there you go. So kind of fun, right? I mean,
Yeah.
anyway. So I just wanted, that was just I wasn't planning to show that, but a little interlude there. And what I did want to talk about was
Wow.
tumor removal, if that's okay. Can
Amazing, Jamie.
Thanks.
Love it.
Love it.
Now you're seeing, I gotta go to switch my presenter mode, right? What do I have to do here? Help me out. How do I move this one screen?
It'd be your bottom right on your PowerPoint
Bottom right.
desktop.
Okay.
Let's see.
Swap to slice. Okay.
There you go. Yeah.
Thank you. Sorry, I can rota through leaflets, but I sure can't use PowerPoint. So I wanted to talk tumor removal for a sec, which is a sort of a different application of electrosurgery, a kind of a precursor case where we came from, and then sort of a little bit of a next gen case. So this particular person, 54 years old, had already had a left atrial myxoma surgical removal, and then he had a right atrial myxoma. That was kind of yanked out basically locally. He was negative for the syndrome, Carney complex, which is a recurrent myxoma, cardiac myxoma syndrome. And so 9 months later, he recurred again, and he was a cardiologist, so he kept putting himself in an MRI machine, and got echoes, which is how he knew about it. This is what it looked like. Sort of a discrete tumor with the stalk right at the SVC-RA junction. This just kind of there. And so this is something that we have been doing for a little while, though I should take no credit, because GI doctors have been doing this forever, and we're just kind of catching up to them, right? Cutting out polyps. And in fact, the first iteration of this, the snare that is the guillotine to cut the stalk, is actually a GI hot snare. GI hot snares, by the way, cost $7. I've never seen any cardiac piece of equipment cost $7. But they've been around long enough that they don't even care. I go to take one and I give them the patient name so they could bill it. They're like, don't worry about it. Just take it. So the idea here is that you kind of load up on the back table a set of snare complexes, where you've got a snare to grab the tumor, a basket to shuttle the tumor out, and then behind all that is the guillotine snare that you can bring forward. So here we snared, like in this still image, here we snared it, then the guillotine snare, the hot snare is advanced forward to the stalk, and then is electrified to cut the stalk off, right? And so we've done a number of those, and this is kind of what it looks like in practice. So we've snared the tumor, we have the basket here, the guillotine snare is brought up to the stalk, so you can see on echo that it's snared. And then I think the next one, now if you pay attention to this, we're electrifying the stalk. This, we didn't capture it all on oops, sorry, hold on. we didn't capture it all on TE, but it will hopefully play here in a sec. But it essentially, you see the bubbles, you get on the echo, if this will play, there we go. See some bubbles and you get the sense that we just cut the stock off there very briefly. And the reason to have the basket system, these myxomas are actually very stable. They don't like disintegrate or fall apart. The reason to have the basket is because many of these tumors, particularly as they get bigger, will not fit into a 26 French sheath, but they do come out and block inside that Ono basket. And so that's what this is here. You just take it all out as one. We've got a safety wire so that we can come right back in. And then you can see you can see the tumor there. They sort of end up taking the shape, even though they start circular, they take the shape of the blood vessel as they come out, they get kind of squished. But this was pathologically confirmed myxoma. And that Ono basket is really the sort of magic of that is, I mean, I've gotten out a tumor that was 4 by 6 centimeters from the right atrium. And I mean, it's like a baseball. And the veins are very forgiving, and the Ono basket just kind of helps shepherd it out. So that's where that really comes into play. And this is what it looks like afterwards. Our surgeons always, I can always find a surgeon who's like, well, you don't have clean margins. And that is true. Though we have done quite a few of these now, because most people don't want to have surgery, open heart surgery, to get these out when they feel fine, and they're otherwise like, why would I do that? What I say to our surgeons is that and this is a little tongue in cheek, admittedly, but I often tell them that, like, if you are cursed to have hair on the top of your head, like Jaffar, you could have a definitive solution. Like, we could scalp you. You might otherwise choose to go and get to a barber to get your hair cut, knowing that your dread consequence of having to go back. That would be terrible. But it's a patient choice thing, I guess. So I mean, who knows what the reality of this situation is. This particular guy has been out a while now, and and he keeps putting himself back in the MRI machine and doing fine. But this is the case that I really wanted to show you. So that's kind of where we started. They had to have a stock. You had to be able to get a snare around the stock. You had to be able to lacerate the stock to guillotine it. But what about cases where you don't have a stock? Because that, with a little bit of success, people are like, well, how about this one? Can you do this? And I think it's actually been a very challenging space. And there are some where you still really can't get them out, particularly if they're on like the free wall and they're broadly adherent without a stock. That's a real challenge. But sometimes they're on the septum, right? And so we had a 74-year-old woman. She was on home oxygen for ILD, and they found this tumor. It's kind of incidentally found, to be honest with you, but sort of showed up on a transthoracic echo, and they're like, what is that thing? Got a TEE, and now you can see that it's relatively big, broadly adherent. Oops, sorry. Relatively big, broadly adherent to the fossa, not involving the mitral valve, but no stock, obviously. And in other views, you can see here, sort of mitral valve is a bit distant to it. Oops, I don't know why these are turning on their own, but but that is that tumor is, it's a left atrium, but on the fossa. So the question is, can we do anything about this? And I do think there's an opportunity here to try and get these out. But the fact of the matter is, we need to get the whole septum out, right? That's what we're talking about, is doing a septectomy, which I think, I don't know if it's a word, but I've been saying it, so I think it's a word. And so, we know how to make a transeptal puncture, right? We can make 1, you can make 2, you can make 3, you can make 4. And if you make 4 transeptal punctures and you know how to do Lampoon or Basilica, then all of a sudden you can start to connect the dots, right? And start to make slices between them all, and then snare and cut it. So we want to cut a flap around it, three slices in the wall, grab it, and then cut that 4th slice, right? So we actually started to get into imaging trouble after 3 punctures, because that 4th puncture, the sort of superior anterior puncture, is not too far away from the right coronary sinus. And I was starting to get a little nervous with the tumor there. And we got 3 catheters in there that I couldn't quite see that. So we decided we're going to go 3 punctures. We'll make some slices. We'll liberalize things a little bit, get rid of some of the equipment in there, and then make that 4th puncture, which is how we did it. And then you just start cutting all the walls. You sort of make that flying V over and over again. They all look similar, so it's not like you can tell them apart. But but we cut the posterior wall first, and then the inferior wall, then the superior, and I left that anterior wall because I was having a hard time finding a nice path between the tumor and the coronary, the aortic sinus. And but eventually we did. And then once we had the flap, we snared the mass, sort of same thing that we had done on the prior case. And then we cut that last little bit. And it all came out basically in block, making the septectomy that ended up being about 1.7 by 1.1 centimeters roughly in space. You can see that whole thing comes out, and there's no more mass. And then we know how to build back. I mean, every structuralist knows how to close one of these guys. So we've just basically put in a ASD occluder, and that was that. And this is kind of what the tumor looks like and this was also pathology confirmed myxoma. So I can't tell you what part of this is fossa and what part of this is tumor. I mean, it gets so kind of mangled in all that, but anyway, so just kind of this is a fun space. I think it's sort of creative, and people are very thankful to not have to go through open heart surgery for a lot of these. I'm falling down on the job, not putting together a multi-center registry, which I do have to do because a lot of people are starting to kick the tires on this, and we need to accumulate some better data. But so far it's been I think it's actually been a very reasonable space. The left atrial side has obviously been a little more novel. The right atrial side was where we all started, and so we'll see where it goes.
Very cool. Did you get clean margins on your last case?
I did get clean margins on my.
There you go.
Scalp.
Because he took the whole heart out.
Yeah.
That's amazing, Jamie. Congratulations. I mean, wow, what expertise you showed there. That is absolutely amazing. Can I just ask, how did you put the flying V on the septum? How did you know, like when you were burning, when you were creating the snare and such?
Yeah, I mean, I think that the V shape is not really the right shape to just pull back onto a flat surface exactly. But it's so hard to otherwise see where you've denuded.
Yes.
You could just kind of make a flat denudation right in front of the microcatheter and try and pull it back. But I basically made the V because it's comfortable to me, and I just didn't make it very sharp. I kind of left it as an obtuse angle, and a little bit of a wide denudation. And then essentially that wall is so thin that like it really doesn't fight back. And so you just pull it back, and as long as you maintain the integrity of the relationship between the flying V and the catheters, you're gonna sort of hit wall with the cutting surface, and that turned out to be true. Now, whether I pulled from one side to another and realistically or pulled flat on it, I don't know.
Yeah.
Congratulations.
You've seen a lot of flying V's. Sorry, how do you have other tips and tricks? I mean, could you do it without making a V? And how would you see it? I'm just asking a question.
Yeah, I mean, the V you still mostly see with the microcatheter. At least for me, as my eyes get older, I rely on the microcatheter to tell me where the V is half the time. And in some ways, you feel the V. If you make a tight flying V, you kind of feel it pop out of the catheters because it becomes sort of free. Jaffar might be able to speak more to that, but yeah, that's how I see it.
I was just going to say the superior to inferior pulls are a nice vector, right? Because you can feed your catheter through the inferior puncture all the way up, and that It's the horizontal pull where you're more kind of bunching some muscle, some wall together to cut. But I think the bunching also works. One thing, just incidentally, that I tried, and this was probably in relation to sesame, was making much bigger denuding surfaces. And what I found was the bigger the surface you make, the less efficient the cut is, you know, by the squared, actually. So it's exponentially much less because you rely on charge concentration to cut. So if you make a nice big generous U or V or whatever, it's kind of disperses the charge a bit.
Yeah.
Amazing.
Yeah.
Wow.
So Jamie, what do you think about using an angiovac instead of a snare and an Ono basket? You know, so you still use a gooseneck to electrify a stalk, say, or, you know, let's stick with a stalk, and then have the angiovac on top of the tumor. Especially for things that are a bit more friable, you know, and that you kind of grasp with that trilobe snare, and you're worried about things flying off, especially on the left side.
Yeah. Well, so let me start by saying I definitely use Sentinel for left-sided tumors. And many I mean, the reason that there's any indication to take out tumors at all is because they're a nidus for clot, right? And as my experience with this has grown, I've come to appreciate that many of the cases that I'm sent have a small tumor and a large mass, because there's plenty of associated clot on top of it, some of which is organized and some of which can be very frondular. And so there certainly have been cases where I will sort of aspirate to debride the mass first and just try and get all those fronds, get as much of the tissue off. And then you end up with a core that is much less friable, and you just can't, I don't think, most of them you can't pull off. Like a real myxoma cannot be tugged off. Whereas like an organized clot, you know, you can. So we have mix and match a little bit with the technology. I think I always get worried about holding a tumor with an aspiration system, because if if you lose integrity of that suction, you lose the mass. And as you're trying to get it across a septum or through a vascular space or whatever, I just have never been as confident that I have it. And then those aspiration systems, by and large, depends on which one you use, but they don't fit through the Ono, which is a 7 French ID. So if you want to use one of the bigger aspiration systems, you can't use the Ono. And for large masses, they just don't fit into a 26 French sheath. And I really have found that I need that Ono to get them out. And I've used that kind of strategy for left ventricular apical tumors that are really well organized. They'll come from the axillary artery and just take them out through an Ono. And that works nicely without having to use a huge sheath. You know, the Ono will fit through basically the smallest it'll fit through is an 11 French ID steerable guide. Works better in the 13.8 Oscor, but so you can kind of downsize your sheaths relative to your vascular bed and still get out large tumors that way.
We like the angiovac a lot, but I think for tumors and big things, the chugging makes me really nervous. You know, when it gets stuck on there, I mean, I worry that I'm going to cause injury by the amount of force that the circulator is creating. So it makes me a little nervous, but
yeah. I've also found, the angiovac idea of giving back. I mean, I'm not hating on angiovac; it's a great device. But if you're pulling from the left side and giving back to the right side, even though you're giving it back, you're sucking a lot of preload out of the left side. And I've gotten to issues with hypotension just by virtue of being pulling out all the left circulation. So I get that part also. I think I've not figured out how to do that right. Anyway.
I think we're at the top of the hour. I want to thank my faculty, Dr. Jaffar Kahn and Dr. Jamie McCabe, and my co-moderator, Dr. Sorajja, for this fantastic webinar. I learned so much, and I hope you guys do too. And maybe next round, on second webinar, we can discuss more cases of these interesting cases. Well, thank you very much.
Fantastic, guys.
Thank
It was
you
really
for having me.
fantastic. Thank you so much.
Thank you.
Bye-bye.
Yeah,
Bye.
thank you. All
Thanks,
right, bye-bye.
guys. Real pleasure. Bye-bye.